personally to do a complete exam. Now, I want you to hear that. Of course, it's important for a patient to have a complete exam, but I want you to focus on some of the things tonight about why it's good for you and why it makes your business change dramatically if you slow down, and why it makes it when you go home at night that you can have the peace of mind that your practice is on the right path. No matter how long you spend with a patient, whether it's a 5 minute at the end of a first visit, some of you I know probably have an exam after a hygiene visit, first appointment. If it's 15 minutes, if it's 20 minutes, if you book an hour and it's separate, it doesn't matter how long you take for that exam. Do you know what the patient thinks? The patient thinks that was a complete exam. So if you're doing it in 10 minutes, 20 minutes, half, they think that. But the question is, what's essential? How can you be accurate without a complete exam? How can you develop a complete treatment plan without a complete exam? And more importantly, and this is what I really want you to focus on tonight in this journey together, is what about discovering signs before symptoms develop? And I'm going to come back and talk about that a little bit more as we go. Okay, so in addition, I've had patients push back because I allowed an hour for a complete exam without hygiene. And that was a little bit of a transition for me when I began doing this because I didn't allow an hour. As my practice gravitated to more complex care, and we screened the phone call and found out that the patient really had, we already knew for sure this was a specialty patient, it became an hour and a half. But not everybody said, okay, you're Dr. Freno, you teach at the Dawson Academy, I'm going to do what you say. They didn't say that to me. They pushed back. They said, how long is it going to take? Can I have my teeth cleaned? And all this that went with it. And I went back and say, how can I fulfill obligation to you? I'm obligated to give information in a way you can understand so that you can consent. So that was one way that I would always get people to settle down a little bit, because a lot of times it's the patient who's driving, go faster, tell me what I need to know, and how much is it going to cost. But it's sometimes it's a doctor, sometimes it's a patient, sometimes it's the nature of our practice. In addition, we have to develop a financial plan, and we have to figure out what the dental benefits are going to be. But the answer to this really is, what does every patient expect? They expect it. And if you spend 10 minutes or 20 minutes, to them, they got a complete exam. And if you spend an hour or an hour and a half, depending on the complexity of the case, it's a different exam. And we're going to talk about how the patient perceives that. But I'm going to ask the question, who deserves it? And I'm going to tell you, every single patient deserves a complete exam. And you're going to say, but Doyle, they're not interested. Every patient deserves a complete exam. If I went to the hospital tonight with this chest congestion I have, which I'm not, at least I don't think I am, fix this. I want you to fix this. Well, you know what they would do? They'd do an exam. I'd get a blood pressure cuff. Hey, whoa, wait a minute. I don't need a blood pressure cuff. I got a chest problem. They might check, all kind of blood work. What are you doing? If I went for a heart situation, they're going to do a complete exam. And we are the physicians of the mascatory systems. Every patient really deserves a complete exam. But let me give you a clue. Let me give you not a clue, but let me give you a positive here. This is when patients choose you, regardless of network participation. Now, I know we've got a broad audience here. A lot of people, there's probably more people in network than out of network. I would bet if I took a poll, that would be the answer. More people are in network. But I bet if I took another poll and said, do you want to be in network? I would have probably a resounding answer, no, I don't. One of the ways I was able to stay out of networks and be fee for service, which made everything better for our business, is because I did a complete exam. And all the time, patients would say to me, I've never had an exam like this. I've never. So if your patients are saying that, then this is going to be a review for you tonight. But you want at the end of an exam for a patient to say on their own, wow. And then you want them to also say this, why hasn't anybody else ever done it? Why hasn't anybody ever else shown me this? Why hasn't anybody else? And when you do that, you've made a patient for life. And what I had figured out later was that's when people said, look, you figure out the dental benefits, but you're my guy. I've been looking for a dentist like you. And you're going to be surprised at the reaction when you slow down and do a complete exam. Let's look at the complete care cycle for a minute. So when we look at the complete care cycle, it starts with the phase one preclinical interview, then goes to co-diagnosis exam, the co-diagnostic exam, then the case presentation, and then the treatment planning or phase treatment. Let's talk just for a minute about the preclinical interview. What does that mean? When you do a preclinical interview, what does that mean to you? Or do you do a preclinical interview? Because, when I talk about a complete exam and records, this patient could have come from an emergency. We allowed meet and greets. Sometimes people would come in with a whole bunch or call with a whole bunch of questions. And we've learned that, we couldn't answer them all, but if we got them to come and meet me and the team and the facility, that they were likely going to say. It wasn't an exam, but that we did meet and greets. Some people did make new patients exams, and some people came through hygiene. And if they come through hygiene, we'll deal with that in a minute. That's where you have to be careful, because if you do an hour hygiene exam and a 15-minute hour hygiene visit and a 15-minute exam, it's going to be very, very hard for you to be complete and thorough. And so at the end of that, guess what the patient's going to want? They're going to want a treatment plan. They're going to want to know what their benefits pay. They're going to want to know how long it's going to take. So not only are you going to do a hygiene visit, well, not only are they going to find you first, then meet the team, then get their teeth cleaned, then meet you, then you're going to tell them as best you can from what you've seen. Then they're going back up front and meet the staff again and talk about money and benefits, and then talk about scheduling. And so that's just TMI. Now, did I ever do that? I did. But what I did with those patients is I would tell them, we're going to schedule 2 hours. And so you can have your teeth clean, and if there's no gum disease, that could be it. But I still did the hour hygiene exam, and I asked them to put a deposit down to hold a 2-hour visit. And you think, well, would people really do that? Well, the ones that really want to come to you will. It depends on how you're getting your patients. If you're getting your patients by referral, then yes, they will. The deposit I had put down was $1 a minute. I wanted it to be something, but I didn't want it to be much. So we described it like this. It's $1 per minute. As long as you give us 24 hours notice, it will apply to your next visit. We can reschedule. But we know that a lot of times things happen on a first visit, and we can't reserve 2 hours of time without a deposit. And some people didn't do it, but most people did. And we're not trying to get everybody. We can't be everybody's dentist, even if we couldn't. I don't, if I owned a restaurant tonight, I couldn't sell every hamburger in Lexington, Kentucky, even if I sold hamburgers. So it really is about having your practice designed so that your life becomes happy and thorough and complete. Then, if we had the hygiene visit and the exam, I never gave a treatment plan, because here's what I've learned. I got a lot of new patients say this. I got my teeth cleaned and I had an exam, and this dentist tried to tell me I need all this dental work to be done, and I didn't believe them. And that's because they didn't go through the process. Now, I want you to keep that in the back of your mind. I probably told them they needed more by the time it was done, but I did differently. Did a preclinical interview. The preclinical interviews where you connect with a patient and you teach them what's normal and you establish what they want and their desire. What's important with a preclinical interview, it should be 10 to 12 minutes, is you're asking a few questions and you're letting them talk. Now, maybe you do this already. I don't know. I know that in my experience as a dentist, most of the time the patients said they've never sat down and talked to the dentist before they went to the chair. And they thank me for it. Because when you come to think about what the patient's thinking. They got to find your office. They show up. They've got all these questions of benefits and time, and they know they got issues. They're wondering if you're going to be nice and it's going to hurt. They come in wound with anxiety. And now we're going to sit down just like you and I are tonight. We're going to sit down and talk. And so I would sit down. I have questions about what is it you're interested in? Tell me more about you. Tell me about your past history. And I started the process of teaching them what was normal and establishing the things that they wanted. 10 to 15, 12 minutes at least, some of the best time you'll ever spend. And patients will thank you. Now you got to be careful because I like to talk, so it can go 30 minutes. So my team would always come in and interrupt me at 10 to 12 minutes. And sometimes patients like to talk a lot. But when my staff would come in and cue me, we got to the point. So it's not an hour preclinical visit, but it's, hey, how are you? Sit down, open up. And it's usually done different than in the chair side, a consultation area. So then you start doing the co-diagnostic exam, and that's where we start to teach people and show people departure from normal. Now, I'm a huge proponent of intraoral camera, and I have an SLR camera too. But I had an intraoral camera starting in 1989. That's how old I am. And it was pretty elaborate to get it all hooked up. And the whole system was $25,000, which was a lot of money now, but it's a lot of money then considering how cheap cameras can be. But I had TVs mounted on the ceiling. And in 1989, I was showing patients, not telling them. I was teaching patients. So we're co-discovering it. The other part of the magic of this exam is how your assistant is involved. The assistant is involved because they're directing the questions, and the questions are from a checklist, and they're asking me the questions. I'm looking at the patient and um, showing the patient in the overhead screen. So it's a co-discovery. Now, this is not a treatment planning appointment. So that's very important if you're taking notes. It's so our psyche to want to be liked because the patient's coming in wound with anxiety. And guess what? We're coming from the side with anxiety too. We want these people to like us. We want these people to accept the treatment that we're offering. We just want to be liked because we spend every day. I know probably today, if you're a practicing dentist, you heard 2 or 3 times at least from a patient, I don't want to be here. You'd say, hello, how are you? I don't want to be here. I like you, but I hate what you do. And that wears on us. Resist this. Stick to being the doctor. Co-discover problems and show, but don't talk about solutions except in general. You don't want to give a treatment plan at this point because you want to take time and plan it and continue with what they want and need. So now when the case presentation comes, you've had a time to organize. They've had a time to think about it. You may send them home. And this is not to be secretive or anything, but I have always found that when I gave treatment plans on the spot at the chair, and then 3 months later, when I'm in the middle of it, I look and it's like, oh man, how did I miss that? And now I've got to say, well, you need something else, or I need to do this different. And it happened to me. Maybe it won't happen to you, but I'm going to challenge you and say that it's going to happen to you. I bet you've had that experience. And that's a very stressful situation to get started and then have to tell them something else. Because what is the patient going to feel? The patient's going to feel like, oh, right, now you got me. Or why didn't you tell me? and you're going to be diminished in their eyes and you're going to be stressed. Or you could ignore it and just wait till later. But if you take your time and then prepare a case presentation, and you've at the end of this co-diagnostic exam, just review with the patient and ask them about it, and ask them if they're ready to, if they want to talk about some solutions next time you're going to come up with it, and feel for any obstacles. A lot of times patients are embarrassed to tell you that, well, my husband's sick, or financially we just can't swing it, or any other, but you want to probe for obstacles so you have a chance to discover, overcome them. And when you do this, the case presentation becomes very, very secondary. People talk a lot of times about, well, what do you say to a patient to get them to say yes? And you can hear all these people promoting articles and themselves saying, how to get your patients to say yes. Well, what I'm telling you is it's not so much what you say, it's what you do, because well done is better than well said. So I didn't have secret magic to get them to say yes, but what I did, developed a relationship, and I worked from what they wanted, and I showed them what they needed, and I told them the things that it was obvious that they knew about, but I also asked permission. I said, look, if you have signs of a problem that I think are going to cause you a problem later, do I have permission to tell you what I find? And they would say yes. And that's what they expected out of a doctor. So and I found myself feeling good about myself being a real doctor. We get told not real doctors. We are. My heart doctor doesn't know a thing about teeth. And just because he doesn't know about teeth doesn't mean he's not a cardiologist. But you don't have to know everything about the body to be a doctor for the part of the body you are a doctor of. And I was acting like a physician of the masticatory system. So that co-diagnosis is the pathway to complete records. When you do this, and you say, in many cases, you're going to say, I need some more records. So let's talk about that. We're going to look at structural issues. We're going to look at biological issues. We're going to look at occlusal issues. Some of you may be new to the Dawson Academy, but I've got news for you. We've got tooth decay and dentistry figured out pretty well. We've got gum disease figured out pretty well. And if patients are interested, they can do that. And we keep searching for better materials and better cements, but we better be worried about how the joint interacts and the muscle dysfunction, because if you haven't practiced long enough to see that zirconia breaks too, zirconia comes uncemented, all those stuff does. So you have to assess the occlusal issues, excessive force. And then you make a recap. So at the end of the exam, I would kind of recap what I found about things that needed to be better, cleanable, structurally breaking down, biologic issues, and then joint and muscle issues. So the exam shows us this, what's the history? Is there a history of past dental work? Most of the new patients I had a history of past dental work. And they also had a history going to the dentist regularly. And so I would say, so let me get this, been going to the dentist every 6 months for all these years. Yes. And you've had all these crowns and you've lost a tooth and an implant. Yes. How did that happen? And they'll look at me and go, what do you mean? How did that happen? What do you mean? I said, well, look, my teeth, I don't have all that. And they go, I don't know what you're getting at. And it's like, well, you've been a passive recipient of dental problems. Now, I've got a couple of crowns back here. Last time I went to my dentist, they found an incomplete fracture. Guess what? It wasn't hurting, but I didn't wait for the cusp to break to end up needing crown lengthening or lose the tooth or endo. I got the crown done. And so become the doctor that says, how about if we discover things that are going to be a problem and treat it so that you're not a passive recipient of all this dental work? I have dental work in my mouth, but I've never had a root canal. I've never lost a tooth. I've never broken a tooth. I've had things done when they needed to be done. You get a good look at the joint. You check centric relation. Can you load the joint? What's the range of motion? You need to do the Doppler exam or joint vibration. What about the muscles? Now it's not just okay, muscles are sore. Which muscles sore? And how sore is this relative to this? Is this is really, really on fire tender? How about here? How about tooth mobility? How about my really underestimate loose teeth? And people tell you all the time, my teeth didn't used to be this crooked. Well, how did they get that crooked? And you say, well, you didn't wear your retainer. Okay, well, wait a minute. What if they're migrating? Because what moves teeth? Teeth move in the direction of the force that's being applied. What if we got the force centered and even and got your bite stable? Your teeth would stop migrating. And what about tooth wear? Well, I'm old. I'm supposed to have worn teeth. I'm older probably than everybody on this webinar. My teeth aren't worn. They're in good shape. And I've had stress in my life. I don't wear a bite guard, but I've also had my bite equilibrated and it's even. It gives you an opportunity to express those things. If your own mouth's not in good shape, that's another thing. Get a good exam, get your own mouth in good shape, because what kind of credibility does that give you with your patients? So that's kind of what the exam summary. Some of the assistant is reading this to me and asking me. And we'll ask the patient, are you happy with your smile? If they say yes, great. If they say no, then we talk about that too. But she goes through all these things. And I'm answering back. So the patient is overhearing this conversation with the assistant and I. And that's a very valuable step for them, so that they hear this discourse back and forth, they're eavesdropping, and they start asking me questions. Well, if that tooth is cracked, what are you going to do about it? What should we do about it? And that is so much better than me telling them their tooth is cracked when it's not hurting, not showing them, and then saying you need a crown. Because whenever I said your tooth is cracked, they'd say it's not hurting, but you need a crown. I'll let you know when it does. Well, guess what? They would let me know when it did, when it broke. And sometimes I wouldn't tell them it was cracked at all. And I would do an exam, and a month later they would break a tooth. And they go, well, how did I break a tooth when I was just in here? A complete exam solves all that. When you make up your mind to be thorough, and when you start having these conversations with your team, you allow the patient to express their desires and their wants. And so when they say, well, if my tooth is cracked, I would say it's not going to uncrack. And they would laugh. They go, I guess not. It's not going to uncrack. And they'd say, well, can I wait? And I said, well, okay, I'll wait with you, but what are we waiting for? We waiting until it hurts? We waiting until there's a budget thing that gets solved so you can do it? And usually when I said that, they would decide they really didn't want to wait, or they'd make financial arrangements. This is where it became happy for me to be their dentist, because I felt like I was being the dentist that I would want to be. I would feel like I was giving them the care that I wanted, because I don't want much dental work. I've never had a root canal. I'll be honest with you. I really don't ever want to have one. I don't want to have a broken tooth. And I don't want, my joint was a problem for a while until I understood what was wrong and went to a dentist who was trained to fix me. I don't want joint problems. I became that dentist for my patients. I felt good about me. That's why complete exams make you happy. You just got to slow down. You talk about the airway. How's the airway? That's very important, because we can get the bite perfect and people are still going to clench and brush their teeth. So if we sit down and make a perfect scenario and their airway's bad, what are we going to do? It's going to break down. So you have to figure that out. It shouldn't be a surprise. How about the joint health? The first one on the upper left, healthy joint. The second one is the tricky one. It's working healthy. It's probably not even clicking, but the muscles are painful. Are we just going to let that be a progressive till it continues to the right, where the disc does tear, and then to the bottom, the ligament tears and it's bone on bone? Are we going to stop this in its track by centering the force in centric relation with even and simultaneous contacts with anterior guidance? We can do that. Whether we like it or not, we have two different types of patients. And this is a key point. And it was hard for me to understand this. Um, no, it wasn't hard for me to understand. It was hard for me to accept it at first. But then once I really started looking at it, it's true. We basically have two big groups. The size contour is working for the patient, or the size contour is not, or they want an aesthetic change. The ones on the left, general patients. We can proceed pretty quickly with a simple treatment plan and take care of them. If the size, contour, and tooth position is working, joints healthy, we can treat those simply. But the other ones are special. It takes more records and exam, more diagnostic records. General patients have problems with their teeth, but a respiratory system that is functioning properly. But specialty patients have problems with their teeth and a masticatory system that is not functioning properly. I challenge you to do this in 15 minutes at the end of a first visit when you meet someone without a preclinical exam. Figure all this out and develop a treatment plan. And I'm going to tell you that if you don't, and that patient continues, you're going to see them develop problems. And then I felt bad. I don't know how you felt. I felt bad because I knew better. I could have prevented this had I slowed down and charged a fair fee, both for me and them, and prevented this from happening. But you have to be able to recognize people that have problems with their teeth and the problem with their masticatory system where it's not functioning properly. Now, so what do I mean by that? Well, if there's no signs of instability, joints healthy, guess what? We don't equilibrate everybody. The Dawson Academy never has said we're equilibrating everyone. We're taking models on everyone. We're not, but we're evaluating, is it working for the patient? And how we know, how are the muscles? How are the joint? How are the teeth? Are they loose? Are they worn? If you see a lot of wear, it's not working because the teeth are in the way and the jaw continues to move, the teeth get worn out. But if that's not there, go for it. Work in the regular occlusion, do the single tooth dentistry, be done with it. If signs of instability, wear, mobility, migration, sore muscles, well, that we have to verify CR. We have to make sure the joint's stable. And if the joint's stable, we work in centric relation and we not only fix the teeth, but we fix the system that is causing the wear, mobility, migration, sore muscles. Because guess what? The tooth is the hardest substance in the body. And if you wear through the enamel, you get to the dentin. That's 7 times softer. So the wear is going to accelerate. Well, guess what else? I don't care what restorative material you put in. If you put in zirconia, you go, it doesn't wear. It wears the tooth above it. It makes the tooth above it loose. It may come uncemented. So you want to balance the force in your restorations because your restorations will break down faster than the hardest cell, which is the teeth. And once patients understand that, I have problems convincing dentists. I never had problems convincing patients. They got it because look in the mirror and see it. If there's signs of instability and medial pole issues, if you have non-verifiable CR, well, you got to stop and you got to treat the joint and get the joints stable and then fix the occlusion. And this is a big source of stress for dentists. We're all afraid that we're going to have a joint problem and get sued. It's going to get worse. We're afraid of it. I was afraid of the teeth. I was afraid of the joint until I started studying it. I realized it's a load-bearing joint. It's designed to take a load. It's not fragile, but it can be abused and break down over time with improper forces. But a complete exam gave me and gave the patient an accurate diagnosis. It gave me the peace of mind to be able to address each case appropriately and not be stressed anymore. That's why a complete exam was good for me. So then in the treatment position. So the exam goes with, as I mentioned, preclinical interview, all the things you see. And if it's a general patient with biologic issue and schedule, if there are function or aesthetic issues, it becomes a specialty patient. And so that exam now is going to require additional records. And most often it requires another visit. But it's easy to do once you sit down with a patient and they come in. When you go to the office tomorrow, you have a patient comes, my joint's clicking and popping. I have headaches. I'm going through a divorce. My child's sick. My parents are ill. I'm just stressed. Well, I'm stressed too. But when my system is designed to take the force, I don't have this going on. And we're here to help you with that in the Dawson Academy. If this is your first introduction, I'm gonna promise you we can unravel this for you and help you understand it so you can be confident with your patient. And when you're confident, that's when your stress level in your business goes down because I had patients. I'll speak for me. I didn't solve. They kept cycling through. It hurts. It hurts. What are you going to do? I don't know. Take a bite guard. Take some muscle relaxers. Well, the bite guard wasn't adjusted right either. First 17 years of my practice, I had no idea what I was doing. I was like, go get some exercise, get physical therapy. I don't know. Then they get better. It's like, whew. Then a year later, oh man, it's killing me, man. What are you going to do? We can help you understand that for your patients and for your sake. When you get through and do the next records, now we come back for more photos. So we take 21 diagnostic photos because now we're going to really look close. And we're going to take mounted models, we're either going to scan them or we're going to print them. We're going to get them on our articulator, either a handheld articulator or a virtual articulator, and this bite is working and not working. And that's patients again. I call an articulator a bite simulator. And those things are old. And I bring them out and I'll show a patient models and they go, well, that's really amazing. They actually kind of think it's high tech. It's not, it's low tech. But you know what else they say? Why did anybody else do this? And when they say, well, my benefits don't pay for it, it's like, okay, they don't pay for broken teeth, but that doesn't mean you don't have broken teeth. We still need to get this done. And they'll go, yeah, I do need to get it done. And we have to have the whole conversation about how dental is a benefit plan, not an insurance plan, which is for another seminar. But very simply, the reason it's a benefit insurance is when they pay $1,000, they're done. It's a benefit. If my house burned down tonight, I'd pay my part. They'd pay the. If I out of here tonight for dinner afterward and have a crash, I'm paying my part. Car insurance gonna pay the rest. I'm insured. Dental benefits, when they pay their amount, no matter what your liability is you have. So patients have a dental benefit. I have to get good explaining that, but we can. Some office work like this, I would have an initial contact, either an emergency exam or a meet and greet. Or if patients want their teeth cleaned, we'd do that too, but we'd schedule more time. Or people would come in and go, great, I heard Dr. Freno's good dentist. Let's do the exam. And then we did the new patient exam. But a lot of guys, I don't know if you can see my cursor or not here, but if you can't, just bear with me. I'm going to take my cursor all the way over to scheduling. A whole lot of times we do that exam and we sort of go really fast through this treatment plan and then maybe a little financial arrangement for the next visit. And then we're off to the races of scheduling. Well, guess what else happens? If I sit down here and do this exam right and take time and understand what the patient wants, I schedule different because I group quadrant dentistry or I do multiple procedures. And you know what a stress-free day for me is? 4 or 5 long visits, or even better, long visit in the morning. What I try to do is 1 long visit in the morning or 2 long visits in the morning, and then short appointments in the afternoon. Specialty patients in the morning, short appointments in the afternoon. Go to lunch at 1, come back at 2, coast through the end of the day. That's why a complete exam is good for you because it made an ideal day. And patients liked it because they got everything diagnosed. If they're going to miss work, go ahead and miss work, come in. We made it comfortable. I didn't rush. We took breaks. And our dollar per hour went through the roof when we grouped multiple appointments. When I used to, and it was a single tooth mindset, you need a crown, come in and get this crown. You need this, come get that. How much time do you have? 40 minutes, stick them in there. My office was chaos. And maybe yours wasn't, but mine was. And so when I settled down, did a complete exam, did a complete treatment plan, understood what the patient wants. If the patient's not ready, you want to know that. I couldn't talk them into it. If their child's sick, they're not ready. They want their immediate care done. Okay, let's do the logic issues. You have some other issues later. Let's do. He knew that because I sat down and talked with him. And so it was stress-free consultations. So the problem is we're trained in dental school just to go tooth by tooth, make the final decision right on the spot, because that's what the dental school educational model is. It's not their fault. They did teach us treatment planning, but be honest, what was your patient pool like in dental school? Your patient pool was probably like my patient pool. They didn't walk into UK dental school and say, I want this young guy to come in here and do my veneers and fix my bite and do this bridge and place an implant. Okay. I did single tooth stuff just like you did. And I learned a lot of the basic skills. But then when I get out of school and these cases are complex, these people who are 50, 55, 60, 70 years old with resources, missing teeth, all kinds of problems, that's a big deal. And they want the treatment, but they assume you know how to do it and you've had all that training to do it in dental school. Well, guess what? I hadn't either. First big case I really did fell flat on my face, had to do it again. And I was a professor at the dental school for 7 years. I was a part-time professor, 7 years. And the first really big case I did, about 12 years out in practice, had to do it over. I went to all my professors and, you could do this, you could do that, you could do, they hadn't practiced this way either. But that's what the market was. And that's what the market is now. That's what's walking into your practice. Maybe your dental school was better than mine was, and maybe your patient population was better. But I think for the most of us, we're trained to do tooth by tooth decision. What I ended up doing is the chairman, my mentor, sent me to a dentist in town who had been to the Dawson Academy. I didn't know that. And he helped me unravel the case and I finished it. And I didn't touch another big case for a year because it traumatized me. I lost a lot of money. The patient was happy. The patient was so happy that I finished. She wasn't mad at all. And here's the worst part. She told everybody. So now everybody starts knocking on my door to these cases. I realized I had to up my skills and I had to get better training. But you know what? When I did that, my stress went down and my happiness went up because I was really doing the care that I would want to do for me. So here's how you treatment plan. You eliminate the pain and abscesses, you get rid of the emergency concerns, you do the endo that's necessary, all that on the left. Down the middle here, if there are functional issues, well, then you start investigating it. Sometimes you start with splint therapy, or maybe it's a sleep apnea appliance, or maybe the patient needs a CPAP. You look at moving the teeth or doing equilibration or both, any kind of perio or implant. And then stage three is the final definitive restorative, where you start with the lower anteriors, then the upper anteriors, then the posteriors to finish your case. And when you break your cases, your specialty cases down like this, so you have all this data from your initial exam, and this is why I couldn't do it chairside. I needed some time, 10 or 15 minutes, not an hour, but I needed 10 or 15 minutes with nobody bugging me to look at those x-rays, think through what she had said, he or she had said, look at it really carefully, ask myself what I would do and develop a treatment plan. And you'd say, well, did you develop an ideal treatment plan for every patient? Yes, I did. That didn't mean they did it, but I developed it. And guess what that was? A good legal record. And if they couldn't do it all at once, I still believed and respected them enough to think that most people want what I want, is a healthy mouth. And so then we looked at how to do it in phases. And I did some cases over 5 or 6 years. We did them in phases and they were loyal to me and it felt good. That's why it's good for you. Because if, dentists, we need to feel good. We need to feel good about our business. Pete used to say dentistry is one of the best hobbies a person could ever have. And if you're not enjoying dentistry, there's something that you need to look at. How can I address this? You remember when you first went to dental school, how excited you were. And the cool things we can do. We can do some amazing things, but we have to organize our business so that it feels good and it's happy for us too, so that we can sustain. I love being a dentist. I'm not tired of being a dentist at all. The treatment plans go through the William rule. And Pete defined the Whittier rule as would I do it on me? And that's a good rule. So we talk a lot about doing the least dentistry to solve the problem. Okay. Careful. You have to be careful of that statement because a lot of patients will say, I want the least dentistry. I want the dentistry. It's like, that's not what I said. I said it's to solve your problem. So we want to solve their problem, but do the least dentistry. If they want elective dentistry, go for it because they're asking you, that's fine. But that's the disposition I had at the treatment plan when I was organizing it. I wanted the problem solved. So if teeth were showing signs of stress, what's causing that? How could I solve that problem? And so that's a Pete quote. That's not a Doyle quote, but we learned a lot from him, and all of us on the faculty that knew him, we miss him very much because there wasn't a happier person to be a dentist or to teach dentistry than Pete Dawson. And one of the reasons that I wanted to do this tonight is because I want you to capture that your life can be supported by your business instead of pouring out your life and feeling like it's sucking the life out of you. And I talk to so many dentists and that's how they feel. So present a complete treatment plan following that principle, break into phases and finances if necessary, and then provide financing options to maximize cover. And you'll find people saying yes. The treatment consultation becomes anticlimactic. You don't have to memorize a bunch of scripts. You don't have to be phony. In fact, if you are, you're going to get a lot of no's. People are wary of dentists. And if you step out of the network, they're even more wary of you because your fees are going to be harder, but they should higher, but they should be because of the value of your service. But revisit what they want. So that's where the preclinical interview is very important. You're coming back for a visit and they know that you know them and they were heard. When people are heard, it's powerful. Talk about the obstacles. See if you can't find a way around them, either through breaking it in phases or I don't present a lot of alternative treatment plans because a lot of times the alternative treatment plans do not solve the problem. And so if I give a treatment plan A, which is what they or I would want, and they say no, well, then I give treatment plan B that's, for instance, I don't do conventional partials. I only do precision partials. I won't present a conventional partial because it's not going to solve a problem. You know why it's not going to solve a problem? We were taught in dental school to make the partial so that we could add to the partial when a tooth was lost. That's a failure. If you present A and B is less, they're going to pick B, but they're going to think it's the same as A. The result is. So I always presented the best treatment plan and break in phases and do it over time. So that's where you come back to optimum health. I tell people a lot, if you had a leak in your roof, but you didn't know about it, you were aware of it, you would want it fixed. You wouldn't want to wait till you had a bucket in your kitchen catching drops of water. And that's the same way people are in their mouth. If they're aware of the problems and the implications and the probability that they're going to have an issue, they want it taken care of. So revisit all that. Then you solve the biologic, functional aesthetic problems, present a treatment plan, have it in sequence. Now, don't just do a treatment plan that's got 10 appointments, $40,000 case when they've told you I don't have the budget for it. You still present the treatment plan, but then you come back to the financial part and say, and you start with the biologic problems first and maybe go to a splint so the structural issues don't get worse. That's where it's important. You get close to your patient in a complete exam. And I'm going to tell you, don't be afraid of it. I never worried about losing patients. I worried about being the best dentist I could be. And the few patients that went somewhere else really weren't interested in having the best treatment. So you say, well, but shouldn't we treat everybody? Well, I never turned away people in pain. I never turned away people in infection. If people didn't have the money for a first visit pain infection, they didn't have to pay me. And if I lost the money, okay. The employees sometimes they get a new employee and they go, so you don't make them pay if they, I said, look, if people are in desperate situation like that, they can't pay, I'm going to get them out of pain. So let me ask you this. If an animal in the parking lot on the way to your car tonight was in distress, would you help the animal? And they said, well, of course. I said, well, I'm going to help the person. But that didn't mean that my office functioned as a charitable organization. Did I do charity cases? Yes, I do. But at the same time, I presented optimal treatment plans. Some people don't want to do that. And I had to say, okay, you can go to where you need to go, but my business is going to focus on this because I think it's best for the patients. I think it's best for the employees because I provided a better job. And I think it's best for me because I'm the kind of doctor I want to be. You don't have to be everybody's dentist. So you get all that stuff discussed. When you're thorough, you start feeling good. When you listen to your patients, you get closer relationships. When you uncover every problem, you're going to be more confident no matter what the response of the patient is. That's a good feeling. And that means you can just relax and run your business and it's going to work. When you build relationships based on trust, the consultations anticlimactic. When you discover these undiagnosed problems, it protects you legally, but it also leads to greater revenue because you complete needed care at the appropriate time. When you help patients achieve their goals, it generates such positive referrals from patients seeking the same. So you get to create the practice of your dreams. You don't have to be controlled by these. When people get all upset, well, the insurance company's doing this, insurance company's doing that. They are. But guess what? They're doing exactly what the contract said they were going to do. You don't have, but you do have to connect with your patient and you do have to be the best dentist you can possibly be. And you do have to have them leaving your practice saying, I've never had an exam like that ever. And when patient reaches that state of total health, guess what else happens? Your emergency visits go through the floor. You stop getting 2 or 3 interruptions every single day. You stop getting phone calls all the time when you're out of work. Your revenue increases. How do you think you'll feel on the drive home? How do you think you feel at dinner? Or in the morning when you get up? You think you'll want to go to work? I'm asking you. Because we all have to work, but it's better to go in a situation like that. It helps you be the best possible dentist you can be. And every single one of you can achieve this because you have enough knowledge. You may have to increase in some areas you haven't studied thoroughly, but you have the ability to do it. And if you have the desire, you can transform your business into something that is great for your patients, great for your staff, and great for you. Okay, I want to give you the next month. One of my best pals is Dr. Jackson. She is awesome with predictable implant prosthesis. She is an expert, and you don't want to miss that. Your next step with us is occlusion and smile design. May 17th through 18th, you can understand a whole lot about what I covered briefly tonight. And I really encourage you to look into this and to go. It was the most important thing I ever did. Let's see now, Q&A. We don't have any questions. I can't believe it. I can't believe that I answered everybody. I'm willing to hang around here if somebody wants to ask voice